very first time with the mid 2022, and we have here Dr. Priyanka Zia, who is an emergency medicine listening. And the topic which we have decided here is the sudden cardiac death. And so, yeah, handing over to Dr. Priyanka. Yeah, continue.
Hello everyone, thank you for the invite, Rohan. So today I'll be dealing with a topic that is sudden cardiac death. Since nowadays we're seeing a lot of increase in the sudden death, whether the patient is 30-year-old, 40-year-old, 50-year-old, that doesn't matter. We are seeing a lot of increase in heart conditions, especially they're just coming to the emergencies with flat lines without any comorbid conditions or without any warning signs before. So I thought it would be very apt to deal with a topic like this today. So today I'll be talking about sudden cardiac death. What exactly is sudden cardiac death? It is the sudden unexpected death of a person because of loss of cardiac function. So according to statistics, if we go with the American, that has very much, they keep a track on everything. So according to them, nearly around 3 lakh to 4 lakh people arrive in emergency with flat lines, with sudden cardiac death, without any comorbidities, without any warning signs whatsoever. So what do you think would be the reason why? And there is an increasing trend nowadays. Like we've seen young actors also dying suddenly, even though they are very much fit with regard to their exercise, with regard to their diet, even though they don't have any bad habits. So, um, so that would be the topic today. So the first most common cause of sudden cardiac death, still till now, like whatever according to the records, that is, we are seeing it as the coronary artery disease. Okay. After that, we have left ventricular dysfunction. That is, especially in patients who are like around 40, 50 years, who have suffered an MI, who survived an MI, who have had congestive cardiac failure. If their left ventricular ejection fraction is very, very low, that means those patients can anytime go into sudden cardiac arrest. That will stand as a second reason only. Okay. So almost we tell it as, if a patient with an ejection fraction less than 35%, he is an ideal candidate to have an electrocard defibrillator implantable, because anytime he can have a sudden cardiac arrest. Okay. So the next common cause of a sudden cardiac arrest includes cardiomyopathies. It could be hypertrophic cardiomyopathy or arrhythmogenic left ventricular cardiomyopathy. Okay. So as we see, hypertrophic cardiomyopathy is, there is without any there is non-dilated hypertrophy of the left ventricle. Okay. So the left ventricle dilates on its own, mostly seen in athletes, in young males, 30 to 40 years of age. And those patients suddenly, without any signs, they'll suddenly have an arrest. How can we see it? In when we do an echo, that is, echo will tell you about the contractility of the heart. So if in an echo, if you see a ventricular wall thickness of more than 30 mm, okay, so that is hypertrophy of the left ventricle. So that patient is suffering from left ventricular hypertrophic cardiomyopathy. So that is also one more cause. And as I told, arrhythmogenic right ventricular
Ma'am, what
cardiomyopathy.
is the basically cause for that young athlete? It is genetic or something which built in lifestyle?
Okay, so most of it has been regarded as genetic. Okay, MI, we know it is because of the lifestyle of the patient. Also, it also has a component of genetics in it, but it is, myocardial infarction is mostly because of the lifestyle of the person. There are a lot of risk factors, be it smoking, alcohol, or his daily lifestyle habits, how, like how active is he in his lifestyle, all those, and his lipid profile, all that will contribute to his, risk of atherosclerosis and the risk of a plaque rupture, all that in an MI. But when it comes to cardiomyopathies, there is no specific cause. It is mostly genetic. Especially in case of hypertrophic cardiomyopathy, patients are very young, and even though they're fit, they're having that left ventricular hypertrophy. It is regarded as genetic mostly than any. identifiable cause. Okay. And then we have other risk factors as well, like the congenital heart disease. Okay. Now, because the survival of a patient with a congenital heart disease has increased, we have better ICU, PICU care, better PICU, NICU cares. So a patient with a baby with a congenital heart disease manages to survive till his adulthood or his 20s, 30s. So later on in his life, there is a chance of having a sudden cardiac death. Mostly, the most common cause attributed is anomalous origin of the left coronary artery. Okay, that is the most common congenital cause where a child can have a sudden cardiac death, because the coronary artery, it will arise between the aorta and the pulmonary artery. So any increase in the venous return can compress the coronary artery, so it will cause ischemia and the infarction and sudden cardiac death. Okay, other conditions include the obstructive conditions uh, of the heart, like Epstein anomaly, TOF, all that. Okay, those are all the other causes of sudden cardiac death in a child with a congenital heart disease. Okay, then we have again valvular heart disease. Again, in the valvular heart disease, also most commonly the obstructive left ventricular obstructive lesions. Okay, aortic stenosis stands the first. Okay, all these conditions would have and many of the times the mechanism is because of a ventricular tachycardia or a ventricular fibrillation. Whenever it is documented, most of the sudden cardiac death, if they occur in hospital, so we'll have a documented rhythm what has happened. If it happens outside the hospital or in the home, we don't have a documented rhythm to assess, to tell what could be the final pathway. But most of the times it is ventricular tachycardia or ventricular fibrillation. So it is ideal to implant a cardioverter defibrillator in such high risk patients, especially if a patient is having a first degree family relative with a heart disease, or he has had any minor symptoms like giddiness or syncope, or when he exerts too much he's having that panting, or he's not as active as his friends or as his colleagues. In all those patients, it is very advisable that they go and get a checkup done. A basic
So
ECG
is
or an
there
echo
any
will at
age
least tell
limit
you
or
whether you're at immediate risk or not.
so is there any age limit that this will be the screen procedure or any age you can do it?
In age you're asking. So I would tell nowadays, because of the increase in the number of deaths that we're seeing, even at 20s, if you have symptoms, if you have a history, early death in your family, or you're finding yourself very weak, very getting exhausted very easily, I think it is an indication, at least get a regular checkup done. So it is not too early. Even in 20s you can get checked. Okay. So the other thing is the cardiac pacemaker and the conducting system of diseases. So we have conditions like the sixth sinus syndrome, wherein the heart does not has its own, like it has a SA node, the sinoatrial node, which will stimulate the heart to pump, right? So any disease of that node or the electrical pathway will decrease the electrical impulses, so because of which the heart contracts less. So when it contracts less, obviously there is less blood supply to the body, so the patient will have syncope, giddiness, and maybe if it is very severe, even sudden cardiac death. So in those patients, again, implantable pacemaker is advised. Again, those are also risk factors, but always first thing is MI, and these are the other causes of sudden cardiac death. And we have other conditions like hereditary channelopathies. Channelopathies are again, uh, just a minute. Can you stop the recording 1 minute? Okay. So as I told, channelopathies. Channelopathies are, see, for any, like we know, for any cell to get activated, there's something called as action potential. After first there's a threshold, then it does an action potential where it depolarizes and then repolarization. So for all these mechanisms, that electrolytes that are responsible, sodium, calcium, potassium, all this. So whenever there is abnormalities in these channels, so those are called as channelopathies. It could be hereditary or it could be acquired. Okay. So these hereditary channelopathies are also one of the common cause of sudden cardiac death. There's something called a sudden arrhythmogenic death. As I told, any abnormality in the functioning of these channels, because for any cell to get activated, we need activation, that is action potential, then depolarization, and then repolarization. For all this, there is exchange of the electrolyte that happens across the interstitium, so the cell and the surrounding fluid. The important ones here, the sodium channel, the calcium, potassium, all these are involved. So any abnormality in these channels will lead to channelopathies. So if it is very dangerous, then it can even take a person's life. So one of the most very important thing is sudden arrhythmogenic death syndrome. Here, a person is totally healthy and totally normal. During his sleep, suddenly he is, no more. He suddenly dies during his sleep. This is again attributed to the genetics or the hereditary part of it. And even though autopsy is done, they are not able to detect any structural cause. Maybe if you put such a patient on an ECG, continuous ECG monitoring, you can maybe find out what could be the possible rhythm that has happened. But it is so unexpected. It is that you can't even predict that this patient will have such a disease. So it again, there are certain diseases where we cannot find out the cause. So this is one of them, the sudden arrhythmogenic death syndrome. Okay. Then we have ion channelopathies. We have the most important one would be Brugada syndrome. Brugada syndrome is where again in this this is also inherited, genetical. It is autosomal dominant. It is more in case of males. It is seen within like in his 20s, 30s. We can say it. What would happen is, in an ECG, normally you'll see P wave, then you have QRS complex, and then after your QRS complex, you'll have a ST segment, and then you have a T wave. You never have anything abnormal, that is, this is for any label that I'm telling, if you see the testis segment is either above or below the baseline, see this. This is the ECG complex. Okay, so after your QRS complex, you see a J wave, prominent J wave, and after your J wave, you're having the I just have user. Okay. After your J wave, there is ST depression, sloping. Right, it's a prominent J wave after your QRS complex. Right. So this patient may be perfectly normal when he comes to your emergency or when he comes to your OPDs. But when you see his ECG, especially in his V1, V2, and V3 leads, these are the changes you see. So such a patient is anytime at a risk of a sudden cardiac death. He might experience little giddiness or fainting sometimes. Maybe he'll admit it, maybe he'll not admit it. But this ECG implies that you should be attentive and you should take you should evaluate him completely. You should refer him to cardiology. Okay, so such patient will benefit from again cardioverter defibrillator, implantable cardioverter defibrillator. So any time if such a patient goes into VT, you have your implantable shock, which will shock him and so that he doesn't arrest. Right. So Brugada syndrome is a very important thing, and noting down, like, not leaving any patient comes with this ECG, do not let them leave your OPD or your emergency without complete evaluation. Right. Uh, Then we have early repolarization syndrome. Early repolarization syndrome is a normal variant. Okay, it is seen in about 1 to 2% of the people, wherein there's a prominent J point. Okay, there's no wave. So after your QRS complex, a prominent J point that you see, and after that, little ST segment elevation will be there. But however, there has been reports where patients with such ECGs later on might have developed an MI. Okay, so you should always keep a check on such patients. But also, this is a normal ECG, right? This is nothing. Again, I'll show you that ECG. This is ECG of an early repolarization syndrome, where you can see there's a proper QRS complex. After that, there's a J point elevation. The J point is where you see after the QRS and the starting of the ST segment. That point is a J point. Then you're seeing a J point elevation, right? And then there's a little ST segment elevation. But again, it should not, if it fits into the criteria of MI, then again it is an MI. Well, this is not fitting into the criteria. But always, it is essentially normal, but you should have a follow-up ECGs, right? Um, then we have long QT syndrome. So long QT syndrome is in an ECG that you see after your P wave, your QRS complex, and then your T wave. If at all your T wave is delayed, ideally when you see a two QRS complexes, the T wave should be less than half of the two QRS complex, the distance, right? If it is falling after the 50%, that means there is QT prolongation. So such patients, it could be again, prolonged QT can be drug induced or it could be acquired, right? These patients are at risk of developing a polymorphic ventricular tachycardias and again sudden cardiac arrest. So any patient with long QT syndrome will require a you can start him on a beta blocker, or you can start him on a, you can, if you suspect a risk, then it is better to go ahead with the implantable cardioverter defibrillator, right? So I would show you the ECG of long QT syndrome. Yeah, see this, if you see, right, this is the normal QRS complex, and then you have your T wave, right? Then this is the next wave. Then you have P wave, then your QRS complex, and the next T wave. This is normal. But then if you see this complex, this is one more QRS complex, and this you have the T wave. Okay.
Yes.
This T wave should ideally fall less than 50 centimeter of the distance, 50% of the distance. So it should fall here. It is falling almost middle, or it is even going that side. That means there is prolonged QT. So again, prolonged QT patients are essential candidates for implantable carotid defibrillator. Right. And then you have your formula also how to calculate QT, where if you have QT divided by root of RR. That is because essentially to normalize it to 60 60 beats per minute. Usually the patient will have irregular rhythm, all that. So that is when you have to calculate it. But if you just see the ECGs, you can tell whether there is prolonged QT or not based on this technique. All right. Then you have again the causes for short QT, sorry, prolonged QT interval. You have hypokalemia, hypocalcemia. All these are causes of long QT. Then you have short QT. Okay. Again, short QT will have less than 0.34 seconds. The QT distance that you check, that is little bit less than 340 milliseconds. Okay. So it mostly causes atrial fibrillations, atrial tachycardia. It can even cause ventricular tachycardias. Again, such patients also are candidates for cardioverter defibrillator. Then we have something called as Staticolomonetic polymorphic ventricular tachycardia. That is, these patients are those wherein a small catecholamine surge or a small emotional stress can trigger a arrhythmia. Okay, so they will have a transient arrhythmias, transient LOCs. Such patients should be detailedly evaluated. Okay, any history of such events during an emotional stress So admit the patient, get a ECG. If that time ECG is normal, it is better to get a Holter ECG monitoring. That means you can monitor the patient for like 24 hours. Any emotional stress that is causing a change in his rhythm. Okay, such patients are again you can start him on the beta blocker because it will subside that, lessen those sympathetic activity. Or if you think the patient does require cardiac defibrillator, you can always go ahead with it. Always implantable defibrillator is better than your pharmacological therapies. Okay. Then so we've covered most of the causes of sudden cardiac death. So now we'd be going to prevention of sudden cardiac death. Okay. So how do we prevent sudden cardiac death? Again, it is not completely possible, but you can take measures to find out whether you are in the risk category or not. Right. Any patients, whatever be the age, whatever you, if you have a family history of early deaths, unexplained sudden cardiac deaths, or any first degree relative who has had early MI, who's having a pacemaker or a defibrillator, anything, is having some history in your first degree relatives, or you have experienced any symptoms like giddiness or syncope or fainting or transient blackouts, okay, or breathlessness sometimes when you exert so much, it is correct. It is always better to get yourself evaluated. Okay. And sometimes after your 30s, 40s, whether you have these symptoms or not, it is better to go and get yourself evaluated. Okay. So what do you want to get checked? What are the basic things that you would get? The basic thing is get yourself checked with an ECG, right? So ECG has been time studied. It will tell a lot about your heart. So whether it is early repolation syndrome or a Brugada syndrome or just a simple tachycardia, a simple stress causing an increase in your heart rate might tell you maybe you're susceptible to a little stress also. So coming to the anti-arrhythmogenic drug and device therapy. So as I told, beta blockers are excellent choice of drugs because they'll always, especially in case of congestive cardiac failure patients, in case of long QT syndrome patients, in all those, it limits the arrhythmias. It'll So beta blockers are always a better drug because they're again cheap and they're effective. But then always implantable cardioverter defibrillator is a better choice. Okay, it has been tested, and then a survival chance of a patient with a defibrillator is implantable cardioverter defibrillator is much more than a patient who is on drug therapy. Right. So it is ideal to categorize a patient who will require what. So for that, which you'll always have to go to a consultant, go to a cardiologist and find out further about your condition. Okay. So, how do you rescue a patient with sudden cardiac arrest? So, it'll be, imagine if you are at home or you're in public, you witness a patient just suddenly collapsing in front of you. So, what do you? So that is when your basic comes to if you're in hospital, obviously you'll activate ACL, that is advanced cardiac life support. Or if you're in public, you'll have to, at least the basic CPR should be known by everybody. So once you see a patient who's had a sudden fall, who's suddenly collapsed, first thing that you go and check is for his carotid, whether he has a central pulse or not. If he has a central pulse, that is when you see just beside his throat, when you just slip your fingers, you can palpate for his pulse, as just the way you see your radial pulse, you can see something pulsating. Okay, if that is not there, that means the patient isn't. Always before going and doing all this, make sure you're also safe, the patient is also in safe zone. Okay. So once is if the pulse is not there, that means the heart has stopped working. That is when you have to make the heart pump so that the blood is circulated to all the vital organs and we don't lose the patient. So you are mechanically doing the function of a heart. How do you do that? You have to give compressions, okay, on his chest. That is again, you have to give it as though the heart itself is pumping, so you have to give it at the rate of 100 to 120 compressions per minute. Okay, some reps may break while you give the compression, but doesn't matter, you're just making sure at least the heart is functioning, right? So whenever you give again, ACLS or BCLS is a separate entity. I'm just briefing about how a person should go about. Again, if you're able to give breaths, then that is fine. If you're not able to give breaths, then at least CPR would do. Immediately activate an emergency and then take the patient to the hospital, or maybe the rescue people will come to your place. So always when a patient collapses, make sure at least you know this, right? So what are the basic four cardiac arrest rhythms that we usually see? There's ventricular tachycardia, ventricular fibrillation, asystole, and pulses electrical activity, right? So survival chance of a patient with ventricular tachycardia or a ventricular fibrillation is much more than the survival with asystole or pulses electrical activity, right? So I'll just show you the ECGs of all four. This is asystole. Okay, so the heart has just
Yeah.
completely stopped working. Okay, there are literally no QRS complexes. There is not even a single limb. Maybe sometimes we'll see some waves, but then it will be not even proper Q. Maybe it is just an upstroke, right? This is asystole. That means the heart has total. There is no electrical activity also left, right? Then this is pulses electrical activity. This, when you say this, you'll have to check for the pulse of the patient. The patient does not have a proper pulse. He does not have a central pulse, but his ECG is showing this. It might be irregular. It could be just a small QRS complex. It could be any rate. The QRS complex might be wide or it could be narrow. So this is a cure. This is just like that is a small electrical activity which is not able to produce enough contractions. So this is just an electrical activity observed, right? Then you'll have you have the ventricular fibrillations, and then you'll have the ventricular tachycardias. Okay, so in these are shockable, right? You can shock the patient and the patient will have his normal sinus rhythm. But as soon as you shock the patient, he might go into bradycardia, but he'll again, the survival chance of a patient with VT or BPB is much more, right? Than and even the neurological deficits that remain after VT is there's less neurological deficit. But if you survive a patient with asystole or with a PEA, he might, there is higher chance that he might survive, but with a very severe debilitating neurological deficits. So this is all about sudden cardiac death. So if there's any questions, you could ask me.
Yeah. Yeah, thank you. And I have some questions from the follower itself. So yeah, first was like from India, it was explain CPR. So yeah, we have done CPR part. And we have from Asia Nicholas. Is like how to sing youngster efficiently to prevent STD. And that also you said we are going to hand is singing for that. And yeah, last one is what are the precautions should be made to avoid STD? STD, that is sudden cardiac death. So what precautions can we do before STD?
Okay. So first question is about CPR, right? Like how to rescue a patient. Yeah. So as I told earlier, so if wherever you are, whether you're in public or in your hospital, any patient collapses, make sure there is scene safety. Pull the patient to a safer zone. Check for, like, first try to arouse, like just call his name or just tap him on his back so that he might wake up. Maybe okay, maybe he'll have some syncope. Maybe he might get up. If he's not getting up, just check for his central pulse. If it is not there, immediately don't even think twice. Just start CPR. Okay, just continue giving compression till an emergency arises, or till a till a intensive, till a physician arrives, right? So that is what you do if you're in a hospital, or when if you are elsewhere. Activate the emergency, call an ambulance, or ask somebody around you to call an ambulance, but you do not stop. You continuously give your CPR, because that is one thing that might help the patient survive, right? So till you reach the hospital, ideally you can continue. And till when can you give CPR? Right. So there is no stipulated time to tell when to stop it. So ideally, till the resources are there, till you're able to perform CPR, you can go up to 40 minutes. Right. It all depends upon ethical issues. It all depends upon, imagine a patient is 95-year-old and you've given almost 30 minutes, and there's higher chance that he might survive, but with a severe neurological deficit, it is of no point, right? So based on many concerns and based on the resources, will take a call on how much time to give CPR. The second question.
Yeah, how to screen the youngster recently to prevent breast injury.
So how to prevent sudden cardiac death? So whatever your warning signs, it has been told that a patient who suffers sudden cardiac death in during his previous weeks or in the 1 month or 2 months or the 6 month period, he might have a little chest discomfort or that not feeling well kind of a feeling, or that syncope, giddiness. These things might be there, but they're very, very non-specific to even consider. But do not be hesitant. Okay, always look for your symptoms. Even a small, when you're trying to walk stairs, like get up on a higher surface, if you have that blackout, or if you feel like fainting, or small little extra work, you're panting, or chest discomfort, or you're really not feeling that well, so get yourself evaluated at least with a basic ECG and an echo. These two are very important, right? And if you have a first degree family relative who has had a MI, severe MI, who is dead, like without any cause, he's just found dead in his sleep or sometime. So all this indicates that you might be in the risk category. So go and get yourself checked, right? So that would be the second question.
That third was the same only. So I have one more question. Suppose if your patient has MI, and normally what will
Yeah,
you give your nitrates? In general
yeah,
terms, we give nitrates.
yeah,
Or we can give that clopidogrel, aspirin, or statin. So my
yeah.
question was, what I know is inferior wall MI, we cannot give nitrates. But when to
Yeah.
get the call of giving nitrates then? If you don't know, if the
And
doctor
to
doesn't take a call at when to give
okay, when
nitrates.
to take a call.
No.
Okay, so that is a very good question, because ideally, as he told, any patient with MI, we give aspirin, clopidogrel, atorvastatin, and we also give nitrates, right? But if you are in outpatient hospital, you're not able to find out whether it is an inferior wall MI or anterior lateral wall MI. In such patients, whether to give nitrate or not is an important, but you can always see his peripheral pulses, right? And also you can go by symptoms. If the patient is having vomiting, or that means the patient is having inferior volume, or you can check for his dorsalis pedis, which will tell you about his approximate systolic blood pressure, right? So that means if his blood pressure is at least good, and what are you worried about in nitrates is that he might die because of hypertension. That is a very important thing in inferior wall MI, right? So these are the things that will help you to decide. But if you're in outside the hospital setting, if you're inside the hospital, obviously we'll limit giving nitrates in an inferior wall MI. But if you're in outside the hospital setting, a patient with chest discomfort, check for his peripheral pulses, look for his dorsalis pedis. If the patient is having altered mental status, that means he's having hypertension, right? In such case also, it's better not to give. But it is also very important drug, because if it is simple coronary vasospasm, it'll relieve the spasms, it will vasodilate it. So it is a very good drug, but it should be cautiously used.
Okay, next we have, is there any correlation between the cardiorespiratory fitness and the incidence of sudden cardiac death in athletes?
Okay, so with respect to cardiorespiratory fitness, I believe that talking about how fit a patient is when they undergo a function, be it treadmill or workload on a bicycle. Okay, how much of oxygen they're consuming, what is their metabolic equivalence, all this. So yes, there has been many studies that have been done, which show that during the 6 5 6 years, or during the 10 year, when they follow up a patient who's had a better tolerance to an exercise, okay, the death rate among them is quite lesser. But a patient who's had early fatigue, early symptoms during a exercise tolerance test, it has been found that there is a risk of early sudden cardiac death in those patients. So yes, there is a link, but it is vast area to be there are a lot of studies has been done, but I would say yes, there is a risk. A patient who has very poor exercise tolerance and who has very high metabolic, which is very high oxygen consumption during an exercise, has been shown to have a very possibility of an early sudden cardiac arrest.
Yeah, next we have, suppose a patient has COVID-19 and we are giving the drugs. Normally
Yeah.
we don't do, but yeah, we have the hydro, so plasma and all. So is that drugs can cause STD or even COVID-19?
Okay. Okay. COVID-19 drugs, rather than drugs, I feel the COVID-19 itself can cause MI
Right.
and sudden cardiac death, because COVID-19 is a prothrombotic state, right? That is what is, it doesn't just affect lung, it doesn't just cause pneumonia, and it is, apart from that, on the longer course, the patient has a risk of those minor thrombus formation, minor plaque formation in their vessels, which can ultimately cause myocardial ischemia and infarction, and it could be myocardial, or it could be even strokes, right? So COVID-19, if not treated, there's a higher risk of developing an MI than the patient with, you know, uh, there is always a better, it is always better thing to get yourself treated, because we always evaluate for your prothrombotic states when we admit a patient with COVID-19. So based on that, we even start antiplatelet drugs, which will prevent the patient, which will at least give some amount of protection from developing a MI later on in his life. So
And last question we have, what are the criteria for attempting to resuscitate a traumatic arrest? So if a patient is in traumatic arrest, because trauma is not arrest. So what are the criteria to resuscitate?
trauma,
Yeah.
what are the trauma to resuscitate a patient with trauma?
Yeah.
Okay, so this is a completely different topic. It is not related to sudden cardiac arrest, right? So we're talking about sudden cardiac arrest in trauma.
Yeah, after because of trauma, there is cardiac arrest.
Okay, so trauma is a very big term. So it could be physical, it could be emotional, it could be a lot of this. So I think what we're discussing about is a physical trauma, be it road traffic accidents. Okay, in such cases, the most common cause of death is hypovolemic shock, because the patient loses a lot of blood. Okay, the second most, it could be obstructive, because there would be tension pneumothorax. There should be, there could be pericardial tamponade, right? This also will restrict the heart from pumping blood to vital organs. And then we also have neurogenic kind of shock. So these are the multiple kind of things with cardiac arrest in case of trauma patients. See, first, in case of trauma, always stop, try to assess, or it could be just hypoxia because of his, trauma to his face, cutting out the blood supply to his oxygen, to his lungs, which is again, hypoxia is also a cause of sudden cardiac death. So try to assess a patient according to airway, breathing, circulation when you see a patient with trauma. If you see a patient who's had an road traffic accident, is lying on the floor over there, again you go and check for the pulse, but also assess, make sure he does not aspirate, right? Make sure he does not die because of his own blood around his mouth. So just give a jaw thrust, and then make sure the airway is patent. Okay, then you look for at least given supplemental oxygen if possible. If not, check for again central pulse. You can check again. You can start giving CPR. It will definitely be helpful, but you should always stop the cause. In this case, it is not primarily because of the heart. See, in all the cases that we have discussed here, the heart is not functioning because of some channelopathy, because of some hypertrophic cardiomyopathy, some structural cause or some electrical cause that is making the heart stop. But in case of road traffic accident, it is secondary. There is too much of blood loss, there is hypoxia, because of this even the heart is suffering, right? So that is the primary cause. Unless you treat the primary cause, even in case of tamponade, the heart is fine, it is functioning, but there's a lot of fluid collected around the heart, so it is preventing the heart from pumping out. Unless you remove that relief of the tamponade or the tension pneumothorax, the patient, how much ever CPR you give, how much ever drugs you use, the patient will not survive. So addressing the primary cause why the patient is arrested in RTA is important.
Yeah, it's we have done the second. Yeah, thank you so much for joining.
Thank you so much for having me.